postdoctoral fellow in Pediatric Emergency Medicine, ICH, HC, and Society for Trauma and Emergency Medicine Pediatrics. She's developed almost 6 chapters in Pediatric Emergency Medicine textbook in undergraduate and postgraduate textbooks. And she's also instructor in PEMC and PREM program by NHM. She has published many journals in many publications in index journals. Ma'am, it's an honor to have you here on this platform. And please go ahead and start the program if you're ready.
First of all, I would like to thank SEMI and Dr. Srinath sir and Yashoda Hospitals for inviting me for this Friday webinars. And I'm very happy to share my experience in the management of Stridor in children. So this is basically a clinical approach where I would be concentrating majority in clinical approach, and if you have any doubts anywhere, I would be happy to answer. So a child with Stridor can be a blessing or can be a bane. It is either way, because as an emergency person, airway is the priority for all of us. All of us understand that in this small space, in this muscular tube, there are so many things which can happen, which can ultimately influence our resuscitation, because airway only allows the oxygen to reach the tissues. If there is no patent airway, there is no oxygen. How much of a resuscitation you do, it's going to be a failure. So as we know, an adult airway and pediatric airways are not miniature adult airways. There are many anatomical and functional differences between an adult airway and a pediatric airway. In an infant towards a child, an adolescent towards an adult, there is a constant growth happening in the multiple areas, and we tend to have narrow nostrils, and the newborns and the infants or smaller kids, they tend to be an obligate nasal breather. So if they have a nose block, that means it is not going to be helpful. And then our occipits are rounded. Tongue is relatively large for the small surface area of the mouth. There is an omega-shaped epiglottis, which is highly floppy. Larynx is higher in the neck, and vocal cords, they slant anteriorly, which makes the intubation process, unless you are practiced, unless you are used to it, it is very difficult to intubate a pediatric airway. And a short neck, which does not give us much space to mobilize, and a narrow cricoid ring, which is the narrowest part in the pediatric airway. So because of this large head relative to body size and rounded occiput, large tongue, and larynx position higher in the neck, there is, whenever the child's head is flexed, a simple flexion of the head forward, the airway can get obstructed and child can lose consciousness. I would come back to you with a case scenario for this. The laryngeal and tracheal cartilages are very soft and they are very pliable. So they tend to be narrowed even with a smaller obstruction. There is a huge obstruction, huge obstruction to the airflow. So whenever you have an infant with a large occiput placed straight in the back, the neck flexes, the tongue falls backward, and the airway gets obstructed. So the airway gets narrowed here. So, and an extension in the sniffing position, what we call it a sniffing position, the airway gets open. The tongue is pulled back and the airway gets open. So this is the basis for positioning the airway in a child who's in an unconscious child. So physiological considerations, even though there is incomplete obstruction, even though there is, you can understand that the infant has a 4 mm diameter tracheal lumen, whereas an adult has an 8 mm. And even if the same amount of circumferential edema, the resistance increases 16 times before 4 times. This is based on the Poisson's law. So what is Stridor? So Stridor is a high-pitched respiratory sound that can be assessed during breathing. So a child has to be breathing for you to recognize Stridor. So in an apneic child, you do not have a Stridor. And the Stridor is produced by the abnormal flow of air in the airways. So this is very important. because this abnormal flow happens in case of an ununiform swelling in the airway. So when there is an external compression of the trachea or the larynx, which is very pliable, very soft, there is an abnormal root, like abnormal block, which can cause a flow. Linear flow can become turbulent. Similarly, when a child is made to cry, a linear flow can become turbulent. A child who comes down with a noisy breathing can get a cardiac arrest if you allow the child to cry in the emergency department. So this is most prominently heard during inspiration. So many number of times, this pliability of the larynx and the pharynx, when inspiration, the child tends to take a deep breath. So there is negative pressure, there is more pliability, there is more narrowing of the airway. So the more, when the air goes through this more narrowed airways, you tend to hear stridor. But does stridor always occurs during inspiration? No, it is not so. Stridor can be biphasic in case of a subglottic, or if the level of obstruction is at the cervical trachea. In the pharynx and supraglottic region, there is an predominantly inspiratory stridor. When there is a block in the thoracic trachea, as in bacterial tracheitis or any bronchitis, you tend to hear an expiratory stridor, which is very, very rare. So we tend to hear predominantly inspiratory stridor or a biphasic stridor, which has more inspiratory. Inspiratory component would be more than the expiratory component. Again, supraglottic stridors versus glottic stridors. The level of lesion also determines the management that we will deal later. So how do you differentiate a supraglottic stridor versus glottic stridors? So supraglottic stridors, as you can remember, the Valdayer's ring and the adenoids, the tonsils, the tonsillar pillars, and the oropharyngeal mucosa and the soft tissue, it constitutes a topper funnel layer. So the funnel shaped upper glottis, that is supraglottis, is wider than the narrower glottis. So in a wider area, there is not much noise. So supraglottic stridors tend to be soft, whereas glottic stridors tend to be very harsh. In supraglottic stridors, majority of the time it is due to inflammatory swelling of the lymphatic tissue, which leads to the narrowing of the supraglottic airway. So they tend to have severe pain as part of the inflammation. So supraglottic stridors, they tend to be painful, whereas glottic stridors, they do not have much space to expand, so they do not have much pain. A voice change, soft potato voice is seen in supraglottic stridors, whereas glottic stridors, you can tend to have barking cough. And toxic look because of the inflammation, because of the infection, because of the abscess formation and everything. The supraglottic stridors, children have a toxic look, whereas glottic stridors predominantly due to edema of the airway because of the viral infection and or any foreign body induced edema, all those things, their toxic look is not much obvious. So now, how do we know how is the airway? So now a child comes with a stridor. So you have localized that the noise is inspiratory, predominantly inspiratory. Now, how do we know how is the airway? Whether the obstruction is all together or there is only a localized area of obstruction. So now what to do if the obstruction is complete, or what to do only if the obstruction is only in partial areas. So now there are variable terminologies which are used to explain this airway, whether the airway is stable, whether the airway is obstructed, whether the airway is maintainable. So how do we understand this? There is no uniform terminology for the airway assessment. So airway assessment, if an airway is, if a child is able to cough, or if a child is speaking to you, if the child is verbalizing with the mother, if the child is able to speak to the mother, or any noise, if you are able to hear any noise when you go near the baby, the airway is said to be open and unobstructed, because there is unobstructed airflow into the lungs for normal breathing. So now if a child is unconscious, if the child is unconscious, airway is said to be obstructed, but can be maintained by simple measures like head tilt and chin lift. That is unstable, maintainable. If the child is not able to maintain or keep the airway open even with this simple process, then we call it unstable and non-maintainable. So this is for our interpretation. So subjective variations can happen in these terminologies. And we have to remember one important point. Airway assessment is predominantly inspiratory, less auscultation, and less palpation. So inspection is the most, and your hearing ability, audible quality of the stridor is mostly completes the airway assessment. So now let us go to the case scenarios. So case 1, this is a 3-year-old boy with history of unresponsiveness since 3 hours, following 3 days of fever and vomiting. He had been lethargic the previous day. The night, the child had not taken anything orally. He had been continuously vomiting. They have reached your emergency department in the middle of the night with unresponsiveness. The mother is saying when the child had been brought to the hospital, the child was able to speak some words, but at present he's not speaking. So now when we, whenever any history like such history happens, we tend to understand what is happening to the child. The basic triage questions: history of ALOC is positive in this child. The child had been lethargic the previous day. History of breathlessness. The mother is not giving any history of difficulty in breathing. So now we proceed to the frame assessment, which says the airway is unstable because the child is unconscious, but you are able to hear soft stridor, palpable stridor. Respiratory rate is only 20 per minute. The child is still breathing, but shallowly, abdominothoracic, and the heart rate is tachycardic. The child's perfusion is normal, but the child's ALOC, child's temperature is, child is febrile, and CBG is only 56 milligram per deciliter. So this child has an unstable obstructed airway. The sensorium is abnormal. So basically, whenever we approach a child with stridor, there are only 4 simple questions. See whether how the sensorium is, understand the duration, understand any significant perinatal preceding event which leads on to this presenting complaints, and try to understand the level of obstruction. So this child's sensorium is abnormal. The child is unresponsive. Duration is only few hours, 1 or 2, half an hour to 1 hour. Mother said the child was speaking when the child came in, but now the child is unresponsive, and there is significant history of fever and vomiting which has led to this unresponsiveness. And because the stridor is only palpable and soft, predominantly this is a supraglottic stridor. So supraglottis starts from the tongue. So tongue, this is an unresponsive child. So as I explained to you, the tongue predominantly occupies the oral cavity. The area of the mouth is very small, but the large tongue which can easily obstruct the airway and cause the narrowness of the airway leading onto this stridor. So the simple maneuver, head tilt and chin lift, can help in the resuscitation very successfully. This child also has hypoglycemia, which leads on to this unresponsiveness. We give 22 to 4 ml per kg of 10% dextrose bolus, followed by IV maintenance dextrose normal saline to maintain the glycemia. So the child, once the child regains consciousness, the airway becomes open. So here, a simple airway maneuver, positioning of the child and suctioning and airway adjuncts. These are the simple measures which can open the airway. Positioning of the child in a responsive child, allow to assume position of comfort. You allow the child to breathe in whichever position the child is comfortable. Elevate the head end of the bed. Even when you are inspecting the child should be sitting. For an unresponsive child, if there is no cervical injury, left lateral position or head tilt chin lift. If there is trauma, jaw thrust. Suction, secretions alone is very important. Unresponsive child, always keep Yanker suction. If the child has secretions in the mouth, suctioning alone will open the airway. And suction nose first, followed by the oropharynx. That is a dictum in pediatrics. Airway adjuncts, keep it ready. If the child is not regaining baseline consciousness even after your initial maneuvers, then oropharyngeal airway or the nasopharyngeal airway can help you to some extent. So now, first thing is positioning of the child in an unresponsive airway. So how are you going to position? So if the child is the more younger the age, the occiput is rounded. Occiput is big compared to the thoracic cavity. So what happens? You put the child down. You put the child at a slightly extended position. The airway, the tongue, even though the tongue seems to be open, the airway gets obstructed. If you put the child normally, the occiput is the bigger area. The chin tends to come to the thorax. So the airway gets obstructed again. So the sniffing position keeps the oropharyngeal, nasopharyngeal, and laryngopharyngeal airways axis in line so that the air moves freely inside. So in case of a pediatric this thing, whenever you are having more younger children, just keep a towel under the shoulder so that the tragus and the anterior upper part of the shoulder is in the same line. So that will help you to keep the child in a airway in a sniffing position, and that is a slight extension to keep the airway patent. So next, if the child is not able to keep the airway open despite this simple measures, what can we do? So here, oropharyngeal airway helps us. Oropharyngeal airway comes in various sizes. That the oropharyngeal airway is measured from the angle of the mouth to the angle of the mandible. So more bigger airway, bigger tubes, it will obstruct the. It keeps the tongue obstructed. More larger tubes can go into the epiglottis, and then it can block the airway. So correct size tubes should be measured from the angle of the mouth till the angle of the mandible, whichever is able to just touch along the palate, just insert and then keep it in position. Nasopharyngeal airway. In a non-traumatic child, nasopharyngeal airway can help to ventilate. We can measure from the tragus, the angle of the nose to the tragus. That will help you select the correct nasopharyngeal airways. There is nasal airways can cause nosebleeds. We have to understand that fact. And because 3 to 6 year old children have hypertrophied adenoids, majority of the times we don't prefer nasopharyngeal airways. We prefer oropharyngeal airways, which is more useful. Coming to the second case scenario, 2 years old male presented in the evening with a history of fever since night and history of seizures 15 minutes ago, uprolling of eyeballs with convulsions lasting 5 minutes, following which seizures stopped, but he has been excessively sleepy. On your examination, you find out that the child's airway is unstable, stridorous. Again, the respiratory rate is shallow, abdominothoracic. Here, tachycardia is there, perfusion is normal, liver span is normal. But when you open the airway, open the eyes and examine, you tend to see nystagmus slit twitch, and there are no obvious convulsions. So this child is in non-convulsive status epilepticus. So here, temperature febrile child and CBG is normal. Sensorium, how are we going to approach stridor in this child? Sensorium is abnormal, unresponsive child. The duration of stridor is within minutes to hours. There is significant presidic event, seizures and fever. Level of obstruction, because this is a soft stridor, it must be supraglottic. So now neurogenic stridor is a functional stridor. It is not obstruction anywhere. The tongue is, even though the unresponsive child, the tongue is falling backward. Once you open the airway, suction the airway, the stridor will be continuing. The stridor may be due to the pharyngeal muscle convulsions. That is one of the postulates. And the second thing is because of huge amount of release of the mediators, the airway goes into edema, leading on to neurogenic stridor. The neurogenic stridor also indicates that the child is continuing to convulse. So we have to follow the status epilepticus protocol. We have to go on escalating the drugs from the previous drugs which the child has received till the seizures is controlled. Advanced airway is an indication for an unresponsive child who is continuing to have stridor. So endotracheal intubation, laryngeal mask airway, these two are the most frequently used preferred methods for advanced airway. Appropriate sized equipment should be available in the ER. And since we have anatomical consideration based on the age, we need to have various size of tubes and the laryngoscope blades, which should be available in the ER. So the vocal cord guide acts as the best way to fix the ET tube. There are multiple number of formulas, 3 times the ET tube and all those things, but the vocal cord guide helps us to exactly place the endotracheal tube in place. So laryngeal mask airway is another supraglottic device which is very useful, which is less traumatic, which is user-friendly, and it is available in various sizes. and you can insert it very easily. But the disadvantage is the aspirations and laryngospasm continue to occur if the airway edema is subglottic. Even below the level of glottis, supraglottic airway devices will do not help, and you have to continue bag valve masking the child till the arrives, like from a anesthetist or a ENT surgeon, when you think that the airway intubation is going to be difficult. So coming to the next case, this so far we have seen unstable airways. So here we have a 10-month-old infant with a history of noisy breathing for the past 6 hours. The child is screaming, crying, and it is irritable. His history of fever for 2 days and cold for 2 days. Parents are irritable, child is irritable. You are also irritable because many a times these kids come early in the morning between 4 o'clock to 6 o'clock. So when the emergency department is almost in isolation, that is when you tend to receive these such children. So you are assessing the child. Child's airway is stable, stridor present. There is a respiratory rate of 40 per minute. Retractions present. So this is a respiratory distress child with a stable obstructed airway and normal heart circulation parameters. Disability is nil. Child is mildly febrile, CBG is normal. So you have this infant. You are hearing a noise. When you time the child, whenever the child takes you are hearing the noise. So this is respiratory stridor, quiet, harsh. Again, the sensorium is, as I told you, the child is irritable. So either an alert or a voice responsive child. Duration of stridor is in hours. Acute, it is acute onset stridor. There is history of a prodrome. Fever is present, cough cold is present. The level of obstruction is either in the glottis or the subglottis. So mostly this child has a ALTB, acute laryngotracheal bronchitis induced stridor, which is due to the infection mediated airway edema, predominantly in the glottis and the subglottis. So here the management, we should not make the child cry. So the it's the dilemma where the emergency doctors and the parents have. So you never separate the child from the caregivers. Allow the child to assume position of comfort. Oxygen should be administered in a non-threatening manner. And next step is to reduce the airway edema. So airway edema is reduced immediately with the help of nebulized adrenaline. Nebulized adrenaline 0.5 ml per kg with a maximum of 5 ml of 1 in 1000 dilution. You use with your oxygen mediated nebulization. That helps in bringing the airway edema less because of the vasoconstriction. The mainstay of treatment is steroid. You can use many routes of administration, either IV, IM, peroral, nebulization, anything is fine. Sorry. IV, intramuscular, in case of a child not able to take orally, and oral administration if the child is able to take orally. Usually single dose dexamethasone is enough, or a repeat dose of, if you have prednisolone, a repeat dose may be administered after 8 hours. Once the upper airway obstruction really is relieved, you tend to have a lower airway obstruction because the edema is spreading through into the lungs. So you have to continue the management with the asthma protocol. And one more important thing is avoid investigations. There is no role for any X-ray or any other imaging parameter to help you in the diagnosis. Other than the therapeutic, other than the So in this video, you can see the amount of anxiousness with which the child is breathing. You can see the retractions, the suprasternal and the subcostal retractions. And we have placed the child in the caregiver's lap, and the nebulization is given, and you can see the tone and posture of this infant. So this child has severe stridor because of the upper airway obstruction, and you can hear the quality of the stridor, which is quite harsh. So this is a typical ALTB stridor. ALTB stridors can be heard in the next room also. The glottic stridors can be heard even when you are entering into the ER. So this is the child, the first child which you had seen situation. So here you can see the alert and happy child, which gives us lots of joy and happiness when we resuscitate such children. So coming to stridorous child with fever. So febrile stridor with odynophagia and dysphagia and drooling of saliva with voice change, that is hot potato voice. And you try to visualize the tonsils in a stable airway child. Tonsils are normal. Think about retropharyngeal and parapharyngeal abscess. Tonsils are enlarged. Think about tonsillar abscess. Tonsils are enlarged and coated. Always keep in mind in a non-immunized, non-vaccinated child, diphtheria. Toxic look, persistent cough, bacterial tracheitis, tripod position, and a non-immunized child, acute epiglottitis, predominantly due to H influenza. In such situation, febrile stridors, be prepared for emergency or elective airway intubation. Keep a smaller size ET tube necessary for intubation. Take universal precautions. Predominantly, these are infective in nature. An anesthetic on-call anesthetist and ENT surgeon should be notified of such a children remaining in ER. They should be available immediately on call if the attempt to intubation fails. Avoid RSI and no investigations. No, strictly no investigations in such children. Coming to the fourth case scenario, this is a 3-year-old boy was brought with sudden onset noisy breathing. So recently we had a child who reached our ER. He was sleeping well. By around 4 o'clock or 5 o'clock, he had a sudden onset noisy breathing, difficulty in breathing, and the only history on probing, the child had consumed seafood in the afternoon. So the child airway was stable, stridorous. He was having choking episodes. The emergency doctor, the doctor who had attended the child, they told he looked like choking. He was not able to breathe at all. He had respiratory distress, tachycardia was present, but perfusion was normal, voice responsive, hyper anxious child. He was mildly febrile, had flushed look all over. So this is an airway stable, obstructed, breathing, respiratory distress, circulation, tachycardia, and shock plus vasodilatory, compensated vasodilatory shock, and a disability, ALOC. Here, again, the sensorium is voice responsive, duration within minutes, hyperacute onset, no significant preceding event. There is a glottic stridor. So this is due to anaphylaxis. Anaphylaxis, all of us know the management is only adrenaline, adrenaline, adrenaline. Why have I written adrenaline, adrenaline, adrenaline? Adrenaline, intravascular adrenaline. If the child has severe wheeze, subcutaneous adrenaline. If the child has stridor, nebulized adrenaline. So IM adrenaline, all of us know, 0.01 ml per kg of 1 in 1000 dilution, deep IM, maximum of 0.5 ml. So most of the time we do not know the weight of the child. So age-based criteria is more than 12 years, it is 0.5 ml. 6 to 12 years, 0.3 ml of 1 in 1000 dilution. Less than 6 years, it is 0.15 ml of 1 in 1000 dilution. Nebulized adrenaline, 0.5 ml per kg of 1 in 1000 dilution. And intravenous subcutaneous adrenaline, again 0.01 ml per kg of 1 in 1000 dilution. Second line is your antihistamines and steroids. They play a major role in maintaining the airway from getting obstructed again because of the release of mediators. 6 years old, 8 months old infant, sorry for the mistake, brought with noisy breathing and recurrent painful stiffening of the limbs. So on arrival, the airway was stable, stridor, pleasant, respiratory rate was 50 per minute, there was retractions. The child had tachycardia, normal perfusion, liver span normal, BP normal, ALOC plus. Alert child, intermittently crying because of the tetany. So this is the infant. So this was in the previous day when the parents recorded the video. We can hear the stridor. We can see the suprasternal retraction and the pain with which his the painful stridor. What will be your diagnosis? Here the sensorium is alert or voice responsive. The duration is within hours to days. There is no significant preceding event. Level of obstruction is in the glottis or the subglottis because the stridor is heard very much. Because of the tetany, we can see the serum calcium is very low, ionized calcium is very low, alkaline phosphatase is increased, 25 hydroxyvitamin D is very less, and you can see the widening rachitic changes in the bone. So this is the left wrist of the infant. Treatment here, there is no role for nebulization because the etiology is due to hypocalcemia. This is the only metabolic cause of stridor. IV calcium, 0.1 mg per kg of 10% calcium gluconate, and along with oral active vitamin D because this child has very less vitamin D, and follow up with vitamin D supplementation and calcium supplements. We have to replace the vitamin D and calcium. So case 6, 45 days old infant, 45 days old, so almost the child had just had crossed the newborn stage with noisy breathing, and mother was worried about the noise with which the infant was breathing, and there was feeding difficulty in this infant. So on assessment, stridor was present, respiratory distress was present, tachycardia was present, but the child was very alert, playful. So here, alert child, acute onset stridor, the mother noticed the stridor for the past 1 week. There is no significant preceding event. There is a glottic obstruction. And because the child did not respond to nebulizations, we proceeded with the investigation where we were shocked to find the cardiomegaly, and ECG showed typical, or all you adult emergency physicians can make out this is a MI ECG. So we had sinus tachycardia with prominent Q waves in the AVL and the lateral chest leads. So this child had a Al-Kappa, and the cardiothoracic surgeon operated on this infant in an emergency basis. 7th case scenario, 1.5 years old child brought in midnight with sudden onset noisy breathing. So this happens between 1 o'clock to 3 o'clock, and there is voice change. The child was brought stridorous, and he was alert, but he had difficulty in breathing. So majority of the time, this is due to the timing onwards, because the child sensorium is alert and sudden onset stridor, the child had slept well, but brought with the stridor in the middle of the night. This is due to the spasmodic croup because of the reflux. The acid in the gut has irritated the airway, leading on to airway edema and the stridor. Treatment is again measures to reduce the airway edema, dexamethasone and nebulized adrenaline, along with anti-reflux medications to follow it. So this is scenario where you can see the child referred to emergency department with noisy breathing. Other found that the rest that the child was missed. So immediately, the first thing which crosses our brain is airway edema, but the X-ray of this child was normal. Sorry, the X-ray is missing. So the X-ray of this child was normal, but since the child continued to have this noisy stridor and difficulty in breathing and bilateral hyperinflation, so CT was done, and if a foreign body was identified, and a vegetative foreign body was removed. So vegetative foreign body is not visible in the X-ray. Similarly, this infant was resuscitated for Bengal gram, roasted Bengal gram ingestion. Choking episode and managed elsewhere. You can see a swelling in the suprasternal region. So the tracheal, there is ballooning of the trachea because of the foreign body obstruction. The X-ray of this infant had shown tracheal ballooning, which led on to subcutaneous emphysema, and this child was intubated and had a very stormy course in the PICU. So the tracheal or carinal foreign body usually presents with stridor, central substernal indrawing. If the foreign body is large enough, it can cause complete obstruction and life-threatening. It is a life-threatening emergency, and it has to be removed in an urgent manner in the theater under the ENT or the pulmonologist with the FFPS or rigid bronchoscopy. If it is large enough not to pass in any of the bronchus and small enough not to cause complete obstruction, it presents with stridor, substernal indrawing. So the level in which the foreign body gets stuck in the airway leads on to the retractions, that is either in the suprasternal area or in the substernal area. Vegetative foreign body, over course of time, the edema of the tracheal mucosa, the moisture of the mucosa can soften the foreign body, and the foreign body can react with the tracheal mucosa and can worsen the airway edema, leading on to a life-threatening near total obstruction. So many a times parents may not realize that the child may have choked unless we ask for the history. So this is frame modification of the stridor. Management of the stridor is essentially, we can see through the course of cases which we have managed so far, the management is basically based on the respiratory distress, level of obstruction, and severity of obstruction. So the more severe the child, more severe the obstruction, the more aggressive is the management. And we have to remember, never ever meddle with airway much other than just managing with nebulization. Always remember to examine the child with stridor in a sitting position. Keep the child with the caregiver. Do not scare the child. Administer oxygen if necessary only in a non-threatening manner. Either free flow oxygen is also acceptable. Unstable obstructed airways, soft stridors are only palpable. Unless we touch the chest, we will not be able to palpate the stridors. Minimal stridors are heard only when you go close to the chest, easy to miss. So the airway remains obstructed throughout. Auscultatory stridors, one stridor which is heard only while auscultation also occurs in mild airway obstruction in supraglottic lesions. In a child with respiratory failure, stridor with respiratory failure, bag valve mask still help arise. Chest thrust and back slaps are only helpful in an infant who is less than 8 kgs or 5 kgs, where you can hold the child and then you can do a chest thrust or back slaps. Call for help or anesthetist or ENT surgeon in case, keep them posted. If necessary, they have to come in case of foreign body, central foreign body, or a vegetative foreign body ingestion. Avoid direct laryngoscopic examination in the emergency department. It has to be done under control situation when the child is sedated and the oxygenation is possible, because meddling the airway can increase the airway edema, and then it can become a cannot intubate, cannot ventilate situation. Avoid paralytic agents in case of intubation. Do not try removing foreign bodies in the emergency department, because again, as I told you, the airway edema can make the ventilation difficult. Airway examination should always be done in control situation, such as in case of retropharyngeal or a parapharyngeal abscess, where you have to incise and remove the this thing, or the foreign body like button batteries and everything. You take an X-ray and you see for button battery in the cricopharynx. The examination, we don't attempt to open the airway and see, try to visualize the foreign body, and do not wait for radiographs all the time. Vegetative foreign bodies are not visualized. In both the cases which I had shared, vegetative foreign body was not seen in the X-ray. Suspicion in the presence of stridor, in the presence of choking episodes. If the mother says the child choked while eating the pomegranate, mother says the child choked when playing with the betel nut, please be careful. This may be a child with foreign body ingestion. Thank you. Thank you for the patience listening. Now, if there are any doubts.
Ma'am, it was a wonderful session. One doctor was asking, is that adrenaline nebulization or steroid nebulization? So you eventually cleared it. It's an adrenaline nebulization.
See, whenever there is a stridorous airway and there is tachycardia, that means the child is going in for hypoxia. You want to reduce the airway edema as early as possible. There we use adrenaline nebulization predominantly. If the child's airway is only moderate, there is no tachycardia, but you are able to hear the stridor, there you can use oral steroids. That is also enough. Or if you have an access to steroid nebulization like Budicort nebulization, you can use that. But there is no role for adrenaline nebulization in that situation. I hope that answers.
Okay. Anyone else? Anyone else has any doubts? Okay, Dr. Arzu has raised a hand. You can type in. So he says upper airway will end at what point?
That's a melody chocolatey question. So upper airway, many a times we say up till glottis, but some of us are comfortable with carina. It does not matter whichever the upper airway is, the glottis or the carina, the management remains the same. So we are not going to, there is not much difference. So the thing is, whether it is glottis or the carina, it's the same.
Another question is like, can you tell the dose of adrenaline nebulization? What is the dose of
nebulization? 0.5 ml per kg of 1 in 1000 dilution, maximum of 5 ml. So if a child comes at 10 kg child, 15 kg child comes to you with stridor, you can give only 5 ml of adrenaline. 0.5 ml of 15 kgs becomes 7.5 ml, but we do not give 7.5 ml, we give only 5 ml of adrenaline.
Okay. Ma'am, how often they can repeat the adrenaline nebulization?
Adrenaline nebulization can be repeated 6th hourly.
6th hourly.
Yeah, 6th
So
hourly.
if the stridor doesn't subside, then what is the next level of action further?
See, many a times stridors, if it is due to ALTB, it subsides. If the stridor is not subsiding, even after your 1 day of this, which happened with our Alcapa child, and we had one basal meningitis infant, the child did not respond to 2 to 3 doses of nebulization. The stridor remained the same because of recurrent laryngeal nerve palsy, the lower motor neuron, all the cranial nerves were involved, and the child had stridor. Or nerve palsy induced vocal cord paralysis, or mass in the vocal cord such as HPV or any such stridors. Many a times it goes into the surgical way or the neurological causes of stridor. So there we need more evaluation. Simple stridors always respond to 1 or 2 doses, maximum 2 doses of adrenaline, not beyond that. If you are not getting enough response, always keep in mind that you are not dealing with simple ALTB, that is something beyond.
Thank you, ma'am. Anyone else? Any other questions? How to treat stridor not respond to medications is what madam told just now.
See, once you feel the sensorium of the child is worsening, an irritable child becomes pain responsive. It's very easy. You secure the airway, you intubate the airway. If the child tends to be showing any other signs like encephalopathy, like this basal meningitis child, came with stridor, he was active, alert. We treated as ALTB for 2 to 3 doses of adrenaline was given, but by evening the sensorium started dipping. So then again we have to secure the airway. There you have to keep the airway intubated, and just once the child sensorium improves, probably an ENT surgeon can help you to see the vocal cord movements. So then you can make a diagnosis of the nerve palsies, recurrent laryngeal nerve or the distance nerve palsies.
Thank you, ma'am. Anyone else? Any other questions? This video will be available on Facebook. You can go and review the video if you want. And the link which is shown in the chat box is will be alerting you the next videos and all the alerts. If you want, you can join the Telegram app. Ma'am, thank you very much for joining us today evening with your valuable talk and valuable time. We are all honored. And I thank Dr. Srinath sir for giving me this opportunity to moderate this session. I thank Dr. Pawan sir and Dr. Lingay sir for giving me this opportunity. And by this, we will end this session today. Thank you so much, ma'am.
Thank you. Thank you very much. Thank you for the opportunity again.